I am by far the least lauded speaker here today, so thank you so much for having me. So what I'm going to talk about today is the use of Y90 specifically in colorectal metastases. And as much as I'd love to have disclosures, I don't. So if anyone wants to offer me them, I will be happy to. The aim of the talk today is to really understand the data behind Y90 and a neoadjuvant approach of use of Y90. And I'm really going to be talking more about a personal experience and my thoughts about this. The older I get, the less data I have in my slides. And I'm going to focus on metastatic colon cancer today. So the first premise that I want to reiterate that you heard about beautifully from Professor Chow is that liver resection is safe after Y90, because that has to be an assumption in order to use it as a downsizing maneuver. And you heard the details already from this talk from Rob Martin's group, and you also heard of this talk using basically from Professor Schoen's group, looking at the proof in concept that liver resection is safe with 13 eligible patients, of which 10 came to resection, and it was done safely. We also have an abstract at this meeting by Professor Schoen showing that 12 of 16 borderline patients were in fact resected, and so it is effective in downsizing lesions to resection. The second premise I want to make is that Y90 is safe with chemotherapy. And I think that's important because oftentimes we're dealing with a systemic disease with the primary in situ, etc. And I want to talk about Sirtex briefly. And really just to say, this study was designed, actually, in my opinion, biased against Y90, but it still showed a benefit in progression in liver-only progression. And you can see in the Y90 plus chemotherapy arm, liver-specific progression was much less than in the other arm. So Y90 is good at controlling metastatic colon cancer in the liver. So how do I synthesize my use of Y90 in a neoadjuvant way? And I would put it down into three groups. One is to treat the tumor but also induce hypertrophy, as you heard beautifully about Artemis, and then surgically resect the lesion. Second is to shrink the tumor away from vessels that are close, making the resection more difficult. And really what I'm talking about is margin accentuation. And then I want to introduce this concept, which really is a concept at this point, which is that you can obtain a pathologic CR in small tumors when you see a radiologic CR. So, you've heard about portal vein embolization. The nice thing about portal Y90 in this, using it in this way is that you get tumor control as well as ipsilateral atrophy and contralateral hypertrophy, as beautifully described by the professor before me. So this is the situation with portal vein embolization where you resect PVE, so you take out the primary, for example, and you do these two, and then you come back after PVE. The concept, and then do extended right. The concept with PVE is, as you saw, you cannulate the portal vein, etc. And a bunch of coils there. But with Y90, the idea is that you could ablate these two lesions, do everything percutaneously, treat the IPSI liver, and then come in and take this out. So that's circumstance number one. Circumstance number two is when you know that your margins are going to be rather poor on a major structure. So I really think about this as margin accentuation or margin sterilization. And just a case that I'm struggling with right now, would love any help with this case, but look at the size of this lesion, which is actually by biopsy metastatic colon cancer, although I have to tell you, to me, this looks like a cholangio. The cytokeratin matrix favor metastatic colon cancer. The patient's primary was resected 4 years ago and was a stage 2 lesion. So the patient got chemotherapy, and I am going to treat this with Y90 to try to give me some margin on these vessels, and I will be hitting up the professors at the podium as to whether this is really resectable or not. You can see my margins are extremely close, and if you go back up over here to my right hepatic vein, you can see that the hepatic vein is extremely close to this lesion right there. So I'm going to be using Y90 in this circumstance for margin accentuation, where I know I'm not going to get a great margin. So the last concept that I want to come across, and really to borrow the idea from hepatic artery infusion, and as you know, Memorial has really popularized this idea, but the issue is, we know from work from Renee Adam that if you get a radiographic CR, or complete response, when those lesions were resected, 80% of those lesions had viable tumor in that. Now, there's a lot of argument as far as the kind of chemo those patients got, etc. But the issue is, does a radiologic CR translate to a pathologic CR? And I would argue that one could use Y90 in a similar way, and then treat the remaining lesions. So let me walk you through a scenario. This is a 66-year-old male who presented with metastatic colon cancer in 2012. He had a sigmoid lesion and 12 liver lesions. This is an Eovist MRI. Now, Eovist is an agent that has a vascular phase, and then you wait 10 to 20 minutes and you get a hepatocyte phase. So white is hepatocyte. Anything that's dropping out is not hepatocyte. Again, Surflox used triple phase CT, and I personally believe, based on our data, where we looked at MR with Eovist compared to triple phase CT, that lesions less than 1 centimeter were detected in MR and not CT in 38% of those patients. So I think we understaged the liver using CT. And Memorial came up with a similar group of data set after us. So these are lesions. Lesions pretty much scattered throughout the liver. Caudate, here, here, here. And whenever we look at these patients, we're always looking at segment 2 and 3 to see if we can do a PVE or Y90 and then an extended right, but everything was involved, every segment. So we treated this patient actually more long than I would have liked to with FOLFOX plus Avastin for 12 cycles, and the CA normalized. This was the follow-up MRI. And this is, again, more chemotherapy than I would have liked. There was a subtle lesion over here. We do know from Surflox that treating earlier is better in these patients. He was doing so well, we actually resected the primary tumor, and it was a T3N1, actually I should say YP-T3N1 because it was after chemotherapy, and we treated the liver with Y90. So one could make the argument, why didn't you just let the liver progress and then treat it? No right or wrong answer there. This was the MDT recommendation. And in November, this was in November 2013, you can see the Y90 treatment. We then treated him with maintenance chemotherapy, a great American concept also. Again, data not great on this, and scans were stable until 2015, where we saw this lesion and this lesion. There was nothing else. Again, his CEA had bumped just a little bit. Colonoscopy was normal. CT chest was normal. So we ablated both of these lesions, and again, the concept I'm trying to get across to you, again, not supported by data at this point, is that I believe that with Y90, a radiographic CR does translate better into a pathologic CR. And indeed, you've got a lovely ablation zone over there, and a lovely ablation zone over here. This is his most recent scan from this past November. Again, shrinkage of the ablation zones, no other disease. So this is using Y90 in a very specific patient that is displaying good tumor biology as a definitive treatment for small liver lesions, and so surgically address the remaining lesions. So he is NED right now. When I was a resident, I thought, what is NED? But it's actually no evidence of disease. And so I think what I would leave you with today is to think outside the box. Do think about intraarterial therapies. Most of the time you are not going to hurt the patient, and you will benefit the patient. You will still get to operate. You won't lose that case, and things will just be easier. I do think that we need to keep an open mind about these things, and one thing just in full disclosure is we were part of Firefox Global, and unfortunately our enrollment was very poor because we are very aggressive with resection and with these bridging modalities. I would like to thank you very much for having me speak. Thank you.